Cellular Proliferation, the long-term threat to capsule clarity. Steve Dewey, Colorado Springs, Colorado. Subtitled, The Clinical Description of the Capsular Bend Breach. I'd like to thank my co-producers, Drs. Liliana Werner, David Apple, Suresh Pandey, Nick Mamalis, Guy Kleinman, and Irmgard Neuhan for their assistance in the Miyake Apple views. I'd also like to thank Bob and Lynn Troshim from Animart for their assistance with the animation. This video will demonstrate the formation and effect of Somring's ring via Miyake Apple views and its clinical impact on our cataract surgery in 2004. I'd also like to demonstrate a clinical capsular bend breach due to Somring's ring formation as a precursor to posterior capsular opacification, and demonstrate how IOL design can undo the benefit of the square optic edge. This slide shows the Somring's ring grading as used by the researchers at Dr. David Apple's lab at the University of Utah. For most practicing ophthalmologists, Somring's ring formation seems to have very little clinical implication. This structure is hidden behind the iris, despite the fact that it forms in every patient following cataract surgery. Probably a better way for clinicians to consider the formation of Somring's ring in viewing myopic apple specimens is to consider it like tree rings, an indication of survival following cataract surgery. The implication is primarily with regard to posterior capsular opacification. The question is, how do you take this, the implant in the bag, to here, with a well-formed capsular bend and clear posterior capsule, and try to avoid this, posterior capsular opacification due to regenerating cortex over time? The problem is cortex regenerates. It happens with every surgery. In this case, it had no resistance to formation despite a plate haptic silicone lens well positioned in the capsular bag. In this case, it had no regard for the fact that there was an SI33-piece silicone in the way. Here we see that it was completely in disregard of a star silicone 3-piece with elastomide haptics. The Acrosoft single piece has only been available for 3 years, and a mature Somring's ring will take well over 5, so this lens remains in question as to whether it will perform as well as its older cousin, the Acrosoft 3-piece hydrophobic acrylic. This lens is the gold standard in preventing posterior capsular opacification despite florid cellular regeneration as seen in the lower right-hand image. But let's take a lens, in this case the Sensor with OptiEdge, out of the eye and turn it on its profile so that we can best examine how this capsular bend forms and how this barrier to Somring's ring can help prevent PCO. The benefit of the square edge in inhibiting PCO is not just the square edge, it's how the edge on the IOL alters capsular contraction and affects capsular healing. It is material dependent. Second-generation silicone and hydrophobic acrylic lenses will induce capsular fibrosis. This speeds contraction of the capsule. It's also design dependent. 3-piece IOLs with larger optics are going to compress the square edge into the posterior capsule, achieving maximum contact pressure. This is going to sequester the posterior capsule and assist in organizing the shrink wrap effect, which is going to ultimately lead to a capsular bend formation. This is going to help avoid posterior capsular opacification early and resist cortical regeneration late. The OptiEdge design innovation has taken away the anterior square edge to improve optical performance of the lens. But does the round anterior edge affect capsular bend formation? Much of what we understand about early capsular bend formation comes from rabbit eye studies such as this one performed by Dr. Okihiro Nishi. He demonstrated the capsular bend formation was equivalent between the Acrosoft double square edge and the posterior square edge of the Sensor AR40E. Effectively stating that we do not need the anterior square edge to prevent posterior capsular opacification. This is a clinical example of the Sensor with OptiEdge, demonstrating an absolutely transparent posterior capsule. We see that the bend is clinically sound, extending from the anterior edge of the capsular rhexis all the way to the posterior edge of the optic. Cortical regeneration is a natural process. It is the result of preequatorial lens epithelial cell proliferation. This process will take place for approximately 360 degrees of the lens equator, and it will result in the formation of Somring's ring. For the purposes of this video, however, we will show it isolated from the 1030 meridian. Somring's ring forms slowly, really slowly. And I mentioned it was a natural process, right? Did I mention that it's rather slow? But at some point, Sommering's ring encounters the capsular bend, and it can be deflected by the fibrosis. If this is the case, the capsular bend will remain intact. Posterior capsular opacification is averted, the regenerating cells circle the optic, and clinically, the anterior capsule fibrosis remains intact. But what happens if these cells manage to breach the capsular bend? They perform a physiologic lysis of the bend. As the cells migrate onto the anterior surface of the optic, this fibrosis appears to be actively remodeled. The capsule overlying these cells becomes loosened. A fibrotic ridge occurs at the anterior extent of these cells, appearing to slow their spread. Once the breach has occurred, the cells can spread posteriorly. There is no remodeling of the posterior capsule necessary. The cells do appear to spread much faster posteriorly than anteriorly, and visually significant posterior capsule opacification may take over a year to develop. At 3 years following cataract surgery, we see the effect of Sommering's ring in this clinical example of the capsular bend breach. As outlined by the green arrows, capsular remodeling has resulted in an area of increased capsular lucency by regenerating cells on the anterior surface of the optic. The secondary effect is posterior capsule opacification. The yellow line will outline the area of increased capsular fibrosis at the leading edge of these cells. This square-edge lens survived for 5 years. However, there are 2 very evident breaches both to the left and inferiorly. The green arrows outline the areas of increased capsular lucency, and the yellow lines outline the areas of increased capsular fibrosis. Perhaps it is best to think of this patient from the Miyake apple perspective. We see here a good correlation for the increased areas of capsular lucency as outlined by the green arrows. For this patient, Sommering's ring is not an arcane perspective, but the process that resulted in posterior capsule opacification and loss of visual acuity. While some innovations of the square-edge design appear to have no impact on capsular bend formation, others do. The bulky haptics of the Acrosoft single-piece lens have been demonstrated by Dr. Okihiro Nishi to inhibit capsular bend formation despite a square posterior edge at the junction of the optic and haptic. In this clinical example from Dr. Gentaro Sugita, we see at the tip of the yellow arrows that the anterior and posterior capsules have fused far away from the edge of the optic. Thus, the capsular bend has not formed a 360-degree barrier towards regenerating cortex. Without a capsular bend to breach, there is no resistance for regenerating cortex. It reaches the edge of the optic and simply migrates across the large, broad base of the haptic into the visual axis along the posterior capsule. The failure of capsular bend formation in this region is attributable specifically to the Acrosoft design and has been termed the Achilles heel of this lens with regard to posterior capsule opacification. Another intriguing finding regarding regenerating cortex was seen in a study performed at the University of Utah in May of 2003. Researchers found no difference in posterior capsule opacification between the Sensar OptiEdge AR40E and the Acrosoft MA60AC, or with the single-piece Acrosoft lenses. However, regenerating cortex was considerably greater in both single-piece lenses, with Sommering's ring formation 50% more with the SA60 lens than with either 3-piece lens design. More concerning, however, was what this cortex was capable of doing. Here we see at the tip of the blue arrow, the bulky haptic of the SA60 lens with no outward compressive force has been displaced out of the equator of the capsular bag by regenerating cortex. This finding thus far has been limited to rabbit eye studies. However, it has been seen at 2 separate studies at 2 separate institutions over 2 years' time. These findings, as presented at the September 2001 Amsterdam ESCRS, also demonstrate that regenerating cortex has displaced the haptic out of the equator of the capsular bag. This finding has clinical implications far beyond that of simple posterior capsule opacification. The question remains whether or not this will be seen in human patients. In conclusion, the square edge works. By forming an effective capsular bend, it creates a barrier to repel regenerating cortex. This prevents posterior capsule opacification but requires good surgical technique to allow its formation. The anterior square edge is not necessary, but IOL design is critical, and 3-piece design is much better than single-piece for long-term clarity. The capsular bend breach is a clinical indication of a previously intact capsular bend. The anterior capsule undergoes remodeling. Decreased fibrosis overlying the area of cellular regrowth is seen on the anterior optic, with a line of increased fibrosis at the leading edge of these regenerating cells. Posterior capsule opacification will follow 1 to 2 years later.